welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Well, hello, and happy Monday, everybody. Welcome to Brain Chat. I'm Dr. Mitzi, the nerdy neurologist, and I am so excited to be back with you all tonight. I hope that everyone has recovered from all of the turkey and all of the fun and family time. And I hope that everyone had a good holiday, because we have an action-packed episode tonight, and I'm so excited about my amazing guests. So you guys know how we do. If you are new to Brain Chat, just log into the chat and let me know where you are logging in from. I bid you greetings from Atlanta, Georgia, where I think we may have actually gone into real winter. We say we have real seasons and fake seasons here. So we had fake fall, and I think now we're actually into winter, which is certainly not as cold as where my colleagues are. All right, so let's get started. I am so excited about my guest tonight. I have Dr. Tanuja Chitnis, who is a senior neurologist, co-director of the Brigham MS Center and professor of neurology at Harvard Medical School. And then I also have Dr. Jennifer Graves, who is a professor of neuroscience and director of the UCSD Neuroimmunology Research Program. And we are talking about pediatric MS, which I think is a topic that is really underserved. So, I spend a lot of time, ladies. Welcome to Brain Chat, first of all.
Thank you for having us. Yeah,
absolutely. So I spend a lot of time talking about underserved communities, and oftentimes when we think about underserved, we may think about people of ethnic minority backgrounds, but with MS, we have some very unique underserved communities, like men, because MS mostly affects women. So I had a very spicy show with some fellas earlier on in the summer about topics related to men and MS, but I also think the pediatric population is one that does not get as much attention as some of our other groups, but certainly very important. And we need to know about pediatric MS. So I thank you both for taking out the time this Monday to come and spend some time with us on Brain Chat. So can we first start by telling us a little bit about yourself, how you got involved in neuroimmunology, and then how you got involved in working with the pediatric population? I'll start with you, Dr. Graves.
Yes. Well, I came across MS the first time when I was about 20 years old, and decided that I would gear my career towards ultimately being able to be an MS specialist. And so I went and did an MD PhD, with the idea being that I would learn how to take care of patients and I would learn how to do research. And fast forward many decades later, and I'm very thrilled to be able to take care of people, both adults and children who live with MS. I'm an adult trained neurologist, but through my fellowships, I had some mentorship on how to take care of pediatric neuro-ophthalmic patients when I was at Penn, and then at UC San Francisco, had exposure through a mentor to take care of pediatric patients. And it's just a really special population, and it's very special to be able to work with families, because really in pediatric MS, we're treating a family living with the disease, and became very attached to being able to work with that population. It's very rewarding, and it's a unique opportunity to step in at a very early time point. We think kids with MS might be more proximal to some of the risk factors to get the disease, and it's a really unique chance to step in early with young people who are going to face living with the disease for a very long time.
Absolutely. Dr. Chitnis.
Yes, well, my MS journey began in residency when I ran into my first MS patient. It was a young woman who unfortunately had a child, and then shortly after that had an attack, her first MS attack. And it really struck me as a disease that affected young people. And I then geared my career and all of my training towards both treating MS patients and also studying it. And, I came across pediatric patients and children with MS when I was the new neurologist on the block, and this is just about 20 years ago now. And there was no one who was aware of MS in children at that time, and these patients were being referred to my clinic and our center in general. And I decided I really wanted to take on and help these young people who are affected by MS. And it's been just a very rewarding journey ever since. And I absolutely love kids in general. I was a camp counselor for my many younger years, and I have my own children, and I absolutely love working with children and teenagers and being part of their growing up. And it's very rewarding to see them now. Some of them I still follow in my adult clinic, and 10, 15 years later, I see them finishing college, going into their careers, having their own children, and that's incredibly rewarding.
Yeah, amazing. Well, I commend both of you. I did my pediatric neurology rotation. And after I had to bribe somebody to walk with French fries, I figured that was not for me. So, so it was me and the child's mom, and we were trying to get them to do an exam and walk to the end of the hall. The mom had to go to McDonald's, get fries, and we're standing at the end of the hall with the fries. And I was like, I don't think this is my calling. So I commend both of you. I do see some pediatric patients, but really more on the teenage side. So more closer to like high school, college age. So let's talk a little bit about, so we've already, you've kind of alluded to a couple of things about how pediatric MS, you get to intervene early. You might learn more about risk factors. Tell us a little bit about kind of the typical age range where we see MS beginning. What's the youngest age that people could possibly be diagnosed with MS?
Well, a couple points there. So most kids with MS come in, interestingly, about a year or two or three right after the onset of puberty. So puberty is a trigger for many kids with MS. In fact, we've done some studies looking at the age of first menstrual cycle in girls, and they usually come in about 2 years after the onset of menstrual cycle. So most kids with MS come in with puberty as a trigger. But there is prepubertal MS. So there are young kids younger than 10 that live with multiple sclerosis. We'll see what Dr. Chitna says, but the youngest patient I felt confident that I was making the diagnosis was at the age of 3. The myelin is the primary target in multiple sclerosis, and myelin finishes forming around the age of 2. So I always have some doubts if MS is diagnosed before the age of 2. And in my experience, a case that I was very certain was MS, the earliest was age 3.
Wow.
Yeah.
Dr.
What about you,
do you agree?
Yeah, what about you?
Yeah.
I would agree that, especially with what Dr. Graves said around MS starting shortly after puberty, and that seems to be a major milestone. My youngest MS patient was also 3 years old, ones that I felt confident about, but it's very rare. So MS is very rare prior to the age of 10. And I think these very young patients, 3, 4 years old that we're talking about are very, very rare. And the majority of our pediatric MS patients are actually teenagers or age 10, 11 and older.
Yeah. So, the youngest I ever had was 9, and I co-managed them with a pediatric neurologist when I was in academics, and it was very devastating. But tell us a little bit about some of the differences maybe between are there differences between like the diagnosis, the symptoms of MS in the pediatric population or how it's discovered versus what we see in the adult population?
Well, overall, it's the same disease. And when we look at the genetic risk factors, they overlap between adult and pediatric MS. So fundamentally, we think it's the same disease, but the host of the disease is different. They're younger, their immune systems are different, their brains are still developing. So some key things are they have a lot of activity. So they have higher relapse rates than adults do. They have more lesions that show up when we do the MRI monitoring, but they recover better due to their inherent ability to repair around damage. So we know young people recover better from everything from a trauma to stroke to a broken leg. Kids just recover better, and that the same is true after they've had a significant relapse of multiple sclerosis. But they are very active. And because of that, we have learned not to be too ginger with treating them, that they have very active disease, and that we're not only treating the kid in front of us now, but we're treating who they're going to be 20, 30 years from now. And so we try to keep both aspects of that individual in mind when we're making decisions about how to care for kids with MS.
Excellent points.
Yeah.
Anything you want to add?
Yeah, I'll add that, one of the challenges of MS occurring in the adolescent or teenage years or even in children is that it's MS on a developing brain. And when MS starts in adults, your brain has developed and myelinated by the age of about 24, 25, but here MS is starting in a developing brain. And so there can be, in some cases, more cognitive issues, and that's something that we screen for very carefully. Part of a pediatric MS evaluation or assessment is a neuropsychological assessment or cognitive testing. We find that many kids are doing just fine, but if there are any issues, it's important to pick those up as early as possible. And especially on the developing brain, we want it to develop as appropriately and as well as possible. And I think the other parts around MS in children is just the psychosocial aspect. It's a very difficult diagnosis to learn about, to hear about. And I always start off by telling all of my patients that, it's now 2023. We have many treatments for pediatric MS that work well, and that it's overall a very, positive course and prognosis, and not to feel dejected about it. And as I'm sure Dr. Graves as well has many patients who now are 10, 15 years after the diagnosis and are doing very well with early and appropriate treatment. So I think those are important things for families to keep in mind.
Yeah. So let's talk about the effective diagnosis on the family, right? So even for my adult patients, who are in their 40s, in the middle of their careers, raising families, it can be very difficult to grapple with, for my college patients, but for a pediatric patient and their family, kind of what kind of tools are there available, or what are kind of recommendations to help them to kind of grapple with diagnosis, or even to explain to them? Obviously a 3-year-old wouldn't understand, or even a 10 or 11-year-old. So kind of how does that conversation go, or when you're trying to or what kind of resources do you direct them to help understand or grapple with diagnosis?
Yeah, I would say that it's a decision and discussion that has to be had with the entire family present, and usually, of course, the patient with their parents, and if appropriate, their siblings. And siblings often wonder what's happening with their sibling and the patient who's affected by MS, and so they also want to be part of the conversation. It depends on the age of the person who's affected by MS. If they're a young teenager, then certainly they should be, part of the initial discussion. They often have many very good questions. Parents are very anxious, and this is something that we see often. They're very anxious about what does this mean for life, for finishing high school, for going to college, for everything that you want to do in life. And I will tell them that, we can manage this very well, that once we are on treatment, that overall, a course, a disease course can be managed very well, and that your young person will do everything that they want to do in life. But I think there's a lot of anxiety in the beginning, usually for the first 6 months or so, until things settle down. Meeting other people who've been affected by MS, by pediatric MS, is very helpful, and there are several groups that are available online, and in some locations in person. I always try to put a family in touch with another family, maybe of a similar age, and maybe if they're boys or girls, then similar gender. And then there are resources online. To the National MS Society is an excellent resource. And often in clinics, we offer a meeting with our family counselor. And I think that several meetings, especially for newly diagnosed patients, are very helpful with a family
Mm-hmm.
counselor, and just to help parents, especially, sort of vent and know that they are also heard. Now, the young person with MS also needs a great deal of support, and
Mm-hmm.
I think through their parents, through school, through having a support system around them, friends, siblings, that's also very important.
Thank you for that. Anything you want to add, Dr. Graves?
I think Dr. Chitnis made some of the most important points. Maybe to emphasize and expand, I often will have conversations with the whole family so that the whole family can hear and be part of it, but also try to create opportunities for each component of the family to ask questions and get support. Meaning, if it's an older teenager, a chance for them to ask questions, if appropriate, without the parents. Give the parents a chance to ask questions that might be, as Dr. Chitnis was saying, from their own anxiety, and to give them a chance to be heard. I think connecting, the kids and the parents with peers, meaning it can be very helpful for a parent who is trying to contemplate using some of these therapies to connect with another parent who's already been through having their child exposed to these therapies, and it gives them a certain level of reassurance sometimes that can expand on what we deliver as healthcare providers, that they're hearing something from their peers about being a parent of someone with this disease can be very helpful. And I think one thing that's very important is to talk about expectations. I usually tell people, expect a 6 to 12 month learning curve. Part of our job is going to be to help you feel educated, provide you with education, but you're gonna master this. We talk to the teenagers and the parents. We're going to give you the tools, and you're going to feel more on top of this in a year. And in the meantime, we're here for you, and we're going to help you. And the other is, I do think we live in a different world than we did 20 years ago, and that the kids are making it to their graduations, they're making it to college, they're starting their careers. I was just thinking the other day, with some of our higher efficacy medications that we now very comfortably use in the pediatric population, and the fact that we're diagnosing kids earlier than we used to, where we have clear diagnostic criteria. I had a couple of kids recently just come to a follow-up, and I don't feel like I have this disease at all. And I just thought, this is so great, and things have changed. And while we can't promise outcomes, we can give some optimism that the other shoe is not about to drop. There's a lot we can do for this disease. Kids do overall fairly well. And the anxiety Dr. Chitnis is talking about is immediately parents are wondering, is my kid going to finish school? Are they going to get married? Are they going to? And that pressure is felt by the teenager. And having very open discussions about that, going ahead and putting on the table what some of that anxiety is stemming from, can be very helpful for the whole family unit. And the other thing Dr. Chitnis mentioned was the siblings. When one person in the family gets diagnosed with a chronic illness, the dynamics in a family change, and checking in on those siblings and how they feel, both their own anxiety about whether they're going to get the disease, as well as how those dynamics are changing in the family around the person who needs more medical care. It's really important.
Yeah. I mean, so those are all excellent points. I didn't think about the siblings, but certainly, that's something that is, a little bit more unique to the pediatric population. Certainly, I do talk to people's family members, with adult MS, but certainly, that focus on the siblings is important as well. So let's talk about treatment. So this has changed. So, I don't treat as many teenagers as I used to, but I remember having a really hard time 10 or 15 years ago getting almost anything approved for my teenagers, and I'm like, we've got to treat, these kids. But we had a hard time getting some of the medications, particularly the more high efficacy therapy. So how have you all seen that change, or the approach to treatment change over the course of your careers? And what's the paradigm now for treatment with MS? Is it the same high efficacy early, or is it still escalation?
Yes, so maybe I'll start with that. And I think that it has changed a great deal. And I would say that when I started treating patients 15 years ago or so, it was very challenging to obtain any medications, high or low efficacy. And now, fortunately, we have at least one FDA-approved treatment for pediatric MS. It is a high-efficacy treatment called fingolimod, and it's a
Mhm.
daily pill that one can take. And that was shown to be superior or more effective in preventing relapses compared to a drug that we were commonly using way back when, an injection called beta interferon. And
Mhm.
so it was much more effective, 82% more effective, in fact. And so that was really a big learning curve, and also fairly safe. And so we learned a
Mhm.
lot through several clinical trials that have been now launched, and that was one of the first that was completed, showing that the drug was safe. And there was a lot of trepidation, a lot of anxiety with neurologists in using these treatments in the pediatric population. And so I think that was a major step forward. And sort of in parallel since then and around that time, in the adult space, we were learning more about high efficacy treatments and the
Mhm.
importance of treating early with high efficacy treatments, and especially in very active disease. And as we've said before, pediatric MS is a very active disease. It's children have 2 or 3 times as many relapses as adults do, so it's very
Mm.
important to get those relapses under control with a highly effective treatment. Other treatments that are also highly effective and they're commonly used in pediatric MS include the B cell therapies, and these usually
Mhm.
come as injections or infusions. And although none are fully FDA approved yet, they are commonly used in the pediatric or adolescent MS clinic. And also a drug called natalizumab, which is also
Mhm.
highly effective. So, I, in general, and I definitely am a proponent of highly effective treatments for pediatric MS. And now that we know a lot more about their safety profiles, they seem to be very safe. We know the appropriate dosing regimens. There are trials that have either been completed or underway with many of these highly effective treatments. So we are much more confident in using them in the clinical space.
Absolutely. That's really exciting because I remember the one teenager I could get natalizumab for maybe 10 years ago. And I'm telling you, it was really difficult. So it's very encouraging, first of all, to know, and I did know that there was an FDA approved treatment for pediatric MS. But it's very encouraging to know that and to know that there's increasing comfort with, addressing the MS and treating it, early with effective therapy. What do you want to add to that, Dr. Graves?
So I completely agree that we've proven there's a clear role to use high efficacy therapy in this population, that the newer drugs do outperform in terms of preventing relapses, which helps kids stay in school, helps prevent some accumulation of injury from having relapses that break through our older medications. And they overall appear to be doing better on the high efficacy medicine. So we're very grateful the community has become more comfortable. The side effects and safety parameters appear similar to adults. So we haven't identified thus far significant differences in safety. We all would love to have 20-year follow-up data on a lot of our medications in adults and kids, but from what we have,
Mhm.
it looks like that we were not incurring any increased risk while we're also giving them benefit. And the other thing I think that's important and similar to adults, but particularly emphasized in this population, is trying to empower these young people to think about their medications, to try to do our best to educate them on why they're taking it. And this becomes really important as they become independent. So
Mm.
we with their parents help launch them into adulthood. And as I'm sure is the same with Dr. Chitnis's experience, what we do in the office visit, and in particular talking about therapy, about why they're taking therapy, that they're preventing future attacks, trying to give them some understanding of the mechanism of why they're on medications, and empowering them with enough knowledge so that when they do become independent, they don't kind of slip between the cracks of the healthcare system or stop taking their
Mm.
medicine because they're actually feeling pretty good. So one of the most important things we do with that population is work to set them up for success in adulthood. So that
Mhm.
when, and so I think Dr. Chitnis, you've mentioned before that you do the same, which is I start having the kids schedule their therapies before they reach 18, have them participate in what it takes to stay on medication before they're out of the house, so that they've practiced some of their healthcare self-advocacy before they leave their parents' home, if possible.
Yeah, so that's an excellent point. And that goes to the next question that I wanted to ask. So in this age of, healthy living, a lot of people are very focused on health, wellness, not putting chemicals or foreign things in their bodies. I see this a lot. And sometimes with my adult patients, we may have to have several conversations about why therapy is important. What are the goals of therapy? Often there's not a cure. Why should I take this? Or if it only works 60%, those type of phrases as people understand, the treatments, or don't understand the treatments. So how do you have those conversations, for instance, with parents who may not be in favor of treatment? Or how do you have those conversations as your pediatric patients begin to mature and maybe they decide they don't want to take treatment? So first, let's start with the parents. So how do we have those conversations, about, the importance of therapy and why, people should go on therapy?
Yeah. Do you want to start, Jen?
Sure, I can start. So, these can be challenging, and people can have fear either of the healthcare system in its entirety, or fear of some of the medications that might be on the market. And I think education is important, and taking some cues from the families. This is a marathon, and so
Right.
losing trust right off the bat is not a way to win the marathon in the long term. So there are times when maybe treatment is delayed longer than I would like, but I give parents and or the adolescent or near adulthood child some time to digest, to ask questions, maybe to get a repeat MRI after their first attack to kind of prove to them that it is still active, even though they recovered very well in the beginning. And the way that I can help them is by preventing more of these lesions from forming. So while I favor early high efficacy therapy, the most important thing I can do the first time I make a diagnosis or meet a family is to nurture a relationship, because this is going to be a very long journey for that pediatric patient, and trying to lay the groundwork of providing education about the disease, about the medications, showing if they're amenable to it, showing them data, if that's something they're comfortable with, providing them with peer support. If they're nervous about taking an infusion, talking to another teenager who does the infusions, again, connecting parents, so that they can have that peer group viewpoint of the situation in addition to the physician viewpoint is very important. So I think it's really important to provide education. It's really important to tell them what I think I would do or what I recommend, but it's very important to listen and to maintain that relationship. And occasionally, if people are very risk averse, we try something that maybe isn't my top recommendation, but I keep them in the fold. I keep them in my care. I tell them that I support and respect their autonomy, and we're going to go through this journey together. And what decision we make today doesn't have to be what we stick with a year from now. So, and that works very well because it's that therapeutic relationship at the end of the day that ultimately is important for medication adherence.
Right. Yeah. And I think that's so important, and also a similar approach that I take with some of my adult patients. And I have seen people who have, seen other, specialists, and, they said if I wouldn't start treatment, they wouldn't treat me. And so I wholeheartedly agree with you that it's important to stay connected. We keep checking, we keep looking, we keep having conversations. I have a couple of patients, I usually am pretty convincing, but sometimes I can't, or people have other reasons they may not want to start, and I certainly do not discard them. I say, hey, just as long as every time we meet, we're going to have another conversation about it. If you're okay, then I'm okay. And we'll just keep monitoring and do what we need to do. What are your thoughts about it, Dr. Chitness?
Yeah, I absolutely agree. It's the relationship and both
Hmm.
maintaining and starting a very effective relationship is very important. It is a lifelong relationship in many cases, and both
Yeah.
Dr. Graves and I treat these young people into their adult years, and so it often is a lifelong relationship. I think that, starting a treatment is critical. So I really
Hmm.
encourage patients to start a treatment. If possible, the high efficacy treatments would be the best, but sometimes there is a level of trust that needs to be gained and really comfort. But I do find that many, especially parents, are really eager and willing and anxious, in fact, to start the best medicine possible. And so I think
Hmm.
there's probably less of a struggle I see in my pediatric population than sometimes in my adult patients, because I think the parents are really want the best for their children. Now, a teenager, that's sometimes another story, and some teenagers are
Hmm.
very highly motivated. They just want to put this behind them. They've unfortunately sometimes had, really challenging symptoms with their first attack, and they don't want to have that happen again. Others sometimes want to just, or not really want, but sometimes are in denial. And they just want this to go away. They don't want to think about treatment. They don't want to think about this disease. And so they may be reluctant to start treatment. And I think that building that level of trust and understanding and also monitoring moving forward. So it's very important to continue to monitor the disease with MRIs. I repeat another
Hmm.
MRI in 3 or 6 months after the first diagnosis. And sometimes that shows new lesions, and that might be enough to convince a young person that yes, this is truly active and that attacks could come back and affect them. So I've had situations where children or teenagers in particular don't want to take medicines, especially if
Hmm.
there are side effects. And so minimizing side effects, trying to treat them, address them right away is also very important.
Absolutely. All excellent points, and I think so important because sometimes it's difficult to, um, you know, I won't say convince, but to emphasize the importance of starting a treatment when someone feels well, when they may have fully recovered from, their relapse or their symptoms and they feel well. It's kind of like, well, why should I take this if I feel okay or I look okay? This may not happen again. And so, I think that sometimes those conversations can be a little tricky and important, for our colleagues to understand, but also, for patient populations, for patients and their advocates and their family members and others to understand as well, that, really we're trying to not just treat the person in front of us, but how they'll look 10 years from now, 20 years from now, as you described, Jen, when you said your patient came and felt like they didn't have the disease. I tell my patients the goal is for us to have social visits where we talk about your MS for 5 or 10 minutes. We look at your MRIs, they look great, you're doing great. And then you tell me where you went on vacation or you tell me what you did last week for the holidays. So, I love having social visits, and I think that we are achieving that more and more. I see a question from the audience that asked about the rising pediatric MS population. Do we see a rise in pediatric MS diagnoses? And if so, why do we think we may be seeing this? Is it because it's easier to diagnose? We have more access to MRIs, or is there something else that may be increasing the incidence of MS in children?
So I can give my take on it. And I think there's a couple of factors, and I'm very interested in Dr. Graves's thoughts on this.
Hmm.
But I think there's, 2 or 3 factors. Why are we seeing more pediatric MS now than, say, 20 years ago? One is that it's better recognized, and this is through the work of a lot of different centers and societies, the National MS Society and other groups who have really, helped us in terms of putting it out there that this is a disease that can affect children as well. We also have better diagnostic criteria for pediatric
Hmm.
MS, and
Hmm.
20 years ago, it wasn't recognized that MS occurred in children. They weren't part of the diagnosis, so big advance. And we're also recognizing other diseases that were sometimes confused for pediatric MS. And now we have some tests for those diseases. One of them is called MOGAD, or myelin oligonucleotide glycoprotein antibody disease. So that was a big mimic of pediatric MS. Another one was
Hmm.
called ADEM, or is ADEM, acute disseminating encephalomyelitis. And now we have clear criteria to to really understand those diseases and be able to better diagnose pediatric MS. So I think it's two things: better diagnostic criteria, more awareness, and also more clinicians who are treating and understanding pediatric MS. We now have training programs for pediatric neurologists to train and learn about treating pediatric MS. We have centers that specialize in this. We have national and international initiatives to better diagnose and also do clinical trials in pediatric MS. So it's really changed a lot in the past 20 years. I think there's a question around, is the biology changing? And there is there's some thoughts around some of the biology might be not changing, but biological factors that we see now in 2020s that might not have been as prevalent in the 1950s might be contributing to earlier diagnosis. One of these is obesity. We do know that obesity is a risk factor for MS in general, and especially for pediatric MS. So this might be a factor in some cases, and obesity is on the rise in general, and it might be why we are recognizing it and seeing it present in younger people.
Very interesting. And what other diseases? So, for instance, with many of my MS patients, I do a lot of work with diverse populations, particularly the Black and African American population. And so many of my patients were told they had psychiatric diagnoses, that, that it was stress, et cetera. Were there common things that the pediatric MS population was misdiagnosed with before we had better diagnostic criteria? Were there common themes that you've seen?
I think that one applies very well. A lot of teenagers with MS present with sensory symptoms. And for a very long time, particularly maybe females more than males across different other descriptors, when they have sensory symptoms, it gets attributed to anxiety or hysteria. And I definitely think that for teenagers presenting with sensory symptoms, I don't think it was being recognized years ago. So I think that does overlap, that idea of particularly those who don't have a very strong motor impact with their first attack can certainly be blown off. Visual changes that maybe happened with a headache probably weren't being recognized every time as optic neuritis in the past in a lot of these, previously underrepresented or vulnerable populations that likely have had MS this whole time. Coming back to your question about epidemiology, we don't, because pediatric MS hasn't been recognized for that long, we have a hard time comparing incidence and prevalence rates because it just wasn't even being assessed prior to a couple decades ago. But there is data in the adult population that I will admit is controversial, but there is data that the incidence of MS is increasing worldwide and being driven largely by incidence in women and being driven on a time scale that's too fast for genetics. So there has been this idea in the epidemiology world for a little while that there is something in our environment, whether, as Dr. Chitnis suggests, it's obesity, which certainly we're seeing an increase of in populations around the world, or if it's something else in the environment. And there's a lot of investigations underway with chemicals in our environment, if they play a role or not, or things that have changed, or other human health behaviors that have changed. So it's an interesting question, and I think I don't know the answer as to whether or not that could be driving more pediatric MS specifically, but certainly there's a lot of interest as to whether or not there is a true rise in the incidence, and if there's something happening in the environment that we could all reverse to decrease increasing cases of MS.
That would be amazing. That would be amazing. I would give it to everybody or give everybody the cure if I could. Do you think we're still missing a lot of pediatric MS? So there are multiple studies that suggest that many people who are diagnosed as adults actually started having symptoms before the age of 18. Do you think I know we're doing better, but do you think we're still missing a lot of it?
I do think so. Yeah.
Go ahead.
Yeah. And I've had, patients who've, sort of come to my clinic at the age of 25. And when I ask them about their symptoms, they'll say, well, yes, I do remember when I was in high school, there was a symptom, or I had visual problems for a few days, and I thought it went away, and I didn't think it was anything, or
Mm,
some numbness that came and went for a couple of weeks. And so people do, when really pressed and prodded, they do recall symptoms that occurred earlier, and it does suggest that maybe their MS likely started earlier. And we do see that, especially in adults in their 20s
mm,
and 30s, on their brain MRIs. There's evidence of both new lesions as well as old lesions. And those
mm,
old lesions, it's very hard to classify them exactly as to when they occurred, but they might have occurred 5 or 10 years prior to their actual diagnosis and when they showed up in my adult clinic.
mhm,
And I think around the issue of diagnosis, especially in children, a lot of symptoms do go unrecognized. And I have stories of kids who've been to the emergency room because they had a fall, and it wasn't the fall that caused their leg to be weak. It was really the leg weakness that caused the fall. But it gets misconstrued and
mm,
a little confused, and especially with young people who may not be able to fully explain what happened. I think that often is a way that the diagnosis, or at least the fact that it's a neurological problem, is missed. So I really encourage, anyone out there, or if you're a pediatrician or seeing children, to really question very carefully whether this is a neurological problem or, due to something else. I think the pediatricians or pediatric community in general is becoming more aware of pediatric MS. Also,
mm.
emergency room doctors, they also need to be aware of this.
Yeah, extremely important. Anything you want to add, Jen?
Just to say, the other thing is, it's not in the textbook, but I have a lot of pediatric patients present with just headache.
Mm,
And I've imaged a couple kids who were only complaining of headache. Now, when I examined them, I found some other things going on, but the only thing they reported to their parents and doctor was headache. And one of the kids stands out in my mind because he had 20 enhancing lesions
wow.
at presentation, and his only symptom was headache. And I just thought to myself, how many other kids might be
Wow.
complaining of a headache, and we have no idea
Mhm,
unless we do a good exam that, he should get an MRI. The other thing I'm going to say is kind of provocative, which is to say there is some epidemiologic evidence when we look at risk factors of disease that maybe almost all MS starts in childhood. If we go all
mm,
the way back to the risk factor point of view, and it's whether or not you were obese in your teenage years. That's the strongest risk factor of obesity with MS. Where you live as a teenager is the biggest risk factor for where you have MS, not where you live when you're 30s and 40s. And so
mm,
there's a thought that all MS is pediatric, but for some reasons, some kids present with that first attack. There's enough precipitating factors that they come in with
mm,
that first attack in pediatric disease. Now, that's an extreme statement, and I don't think that's the case in everyone. I've certainly met older adults that I think I caught the very beginning of their disease with MS based on imaging and clinical features. But it's pretty provocative to think that maybe MS really is starting quite early in life, and then there's a variety of factors that determine when that first clinical event is that gets attention from the medical system.
mhm. And it's a very interesting point, right? Because we're talking a lot in the research community about the MS prodrome, right? So if someone starts having kind of vague issues going on 10 years before they actually manifest a symptom and they get diagnosed in their 20s, I mean, that would be in their
Pediatric
teenage years,
onset, yeah.
so it's very interesting. One of the things that I love about neurology and neuroimmunology is that I feel like we're on the cutting edge of medicine. There's so much that has just changed even in the past decade, in the past couple decades, and it seems like every year we're finding out something new, and so that's one of the things that's really exciting. What are you excited about? Is there any research or any projects that you're excited about that you're involved in the pediatric MS population, that you are excited about and want to share?
So I think, two things that I wanted to share. One is there's some really interesting work on diet, and this is
Mm,
coming out of the US network from Dr. Emmanuel Wabant's work. But there's really consistent data showing that a vegetarian or more vegetable heavy diets might reduce relapse rates. And that seems
mm,
to make a lot of sense. There are some links to metabolites, there's some links to a better gut microbiome. We're now learning a lot about the trillions of bacteria that live in our guts, and if you feed them with the correct nutrients, and especially it seems that vegetables are very helpful, high fiber diets, that seems to reduce inflammation. So I tell my patients, it doesn't hurt to just watch your diet. I think stay away from processed foods as much as possible, and I think there's more and more data around supporting a more vegetable-rich diet, vegetables and fruits. And the other thing I'm very excited about is the fact that we are becoming even more comfortable around treating pediatric MS with high efficacy treatments, and that there is a number of ongoing clinical trials that are either have started or are starting up to continue to test these high efficacy treatments that are approved in adults. And so that is hopefully going to give us more FDA approved treatments for pediatric MS. And that's very promising. So I encourage you and anyone who's involved in pediatric MS to consider clinical trials, and hopefully we can get more treatments fully approved.
Amazing. Jen.
So I agree with Dr. Chitnis that the kids, I think, may hold some really interesting keys about environmental and lifestyle factors for MS. I'm really excited about what we've learned so far and what we're going to continue to learn about what causes MS. They're young. They've only been on planet Earth for so many years, and we have a much better shot, I think, at getting at the origins of disease in this population. So really excited about the work that's happening in the US and internationally to go after the cause of MS by learning and studying kids with MS. So I think that's very exciting. And, as Dr. Chitnis just highlighted, we're learning about lifestyle factors as well. Diet, physical activity has been linked with relapse rates in pediatric MS. And the other thing about lifestyle is we do have this, in addition to the other advocacy I was talking about before, we have a unique opportunity to try to change behavior with young people. And there's a lot of studies showing that health, behavior, exercise, diet, you've got a really unique opportunity in this age group to intervene. And if we intervene early, we might be setting them up for an entirely different trajectory of living with this disease by doing that. And I think that's really exciting. And then the other flip side is, kids do recover better. We have some data. Dr. Chitnis led a study showing us that kids recover better. And I think kids, in addition to teaching us what causes MS, maybe they can teach us how to repair an MS. So, we think of a lot of the work that we've been doing to figure out repair and neuroprotection and recovery. We're doing it in the population that appears to need those therapies the most. But I'm really excited about what we could learn from the natural process that kids use to recover and repair and remyelinate. And I'm really excited about the frontier of studying those types of agents in this population and seeing if they can give us the key of how to help their co-patients that are 20, 30 years ahead of them by studying what works well in them that then changes across our lifespan.
Wow. Well, listen, I'm excited, and I don't even work in pediatrics, but I'm excited about all these amazing advances and, about the amazing work that both of you are doing. I know that you both are leaders in this space. And, I think it's so important that people have a passion, for certain populations. I mean, think about how much we've learned about pregnancy and breastfeeding in MS because people have a passion. I've got girlfriends, every time we sit at the table, they're talking about breast milk samples and things like that, So I clearly see that passion in both of you. And I'm so grateful for the amazing work that you're doing to help us understand, MS in this underserved population, but very important, and the kids wind up teaching us about many things. And so I hope that, some of these advances will definitely help everyone with MS, so that we can better understand the disease and make sure that we're treating people optimally. So thank you all so much for your attention. That time went by so quickly, but I thank you so much for your expertise and for, your wisdom. And are there any, last tips that you would offer, to that family out there that's newly diagnosed, with their, child having MS, or to that new pediatric patient who's new to the disease?
I
There
would
are many
say,
good ones. Go ahead.
Sorry. I would say that know that there are specialists out there. There's many resources out there for pediatric MS, and that there are centers and specialists that care for kids with MS. They may be a little bit further away from you, but it certainly is an option to visit them and have a consult. And the fact that there are many more resources and treatments that are coming hopefully down the pike soon, that's very positive. So it's a really it's a tough diagnosis, but it is a very good outlook and prognosis for these young people.
Amazing.
I would just follow that up to say there's many good reasons for hope. There's an amazing group of people out there that want to partner with you and support you. There's a community to be there for you if you're going through this, and you will become the experts in your own path with living with this disease as a family. And there's many bright moments ahead, in addition to any difficult ones. Many bright moments ahead.
Amazing. Well, thank you so much, Dr. Graves, and thank you so much, Dr. Chitnis. And thank you to everyone watching Brain Chat. I hope that you all got some amazing information, and we'll see you again in 2 weeks.